Well, thank you very much, Margot. Appreciate it. And the screen ought now to be reflecting Mike Leavitt, who is coming in via video from Park City, Utah. I think they got about 20 inches of snow last week, so a real contradiction from the 80-degree weather we're feeling here. I don't know, can you hear us, Governor?
Yeah, oh yes, I hear you and I see you, and I would like to be seen and make it clear that I have no ski boots on underneath this suit.
That's good. Well, we're glad you're here, and the room is filled at the Healthcare Datapalooza, the one conference that makes you smile just by hearing the name, and we're grateful to welcome you here. Let's start out with just a background. Let's set the landscape for healthcare generally and kind of what we see in the new administration. We have definitely taken the lid off of the uncertainty bottle again, but there is a landscape that's quite visible to us, and I'd love you to just kind of explain that.
Well, first, I want to thank the organizers of Datapalooza for allowing me to join you this way. And secondly, I would like to acknowledge that we are in a period of some uncertainty. There was a great German general who referred to the fog of war and said that that's the confusion that happens when there's uncertainty. And he gave a very important piece of advice, and that is that in certain situations you have to gain what he referred to as battlefield awareness. And he essentially said, go to a higher point where you're able to see the whole field and not be so caught up in the day-to-day movements of what are occurring. You have to be able to see the entire battlefield. And I would like to suggest that there is a much larger field than what's happening in Washington right now. In fact, I would like to suggest that if we could use Google Earth and go all the way out and see the Earth as in total, as opposed to looking at what's happening right in Washington, D.C., we would see that this healthcare debate is actually that we're 25 years into a 40-year transformation, and that we are iterating as we go, and that we're moving toward a much different healthcare system that's based on global economics, that it isn't just being driven by what's happening in Congress today, that we're in a place where we have to find a solution because there's no place on the economic leaderboard for a country that spends 25% of its gross domestic product on health care. And yet we find ourselves in some ways split between two imperatives. One is the imperative we feel as a nation to be a compassionate nation, and it's completely unacceptable for us to abandon that sense of compassion. And secondly, we're looking to guard our economic leadership, because it's what makes not just our country, but to a large degree the entire world. And so just opting for straight compassion or opting for straight economics doesn't work, and it's what's driving us toward this uniquely American system that I believe is going to start by transitioning away from fee-for-service payment toward value payment, and that what we're seeing happening in D.C. right now is essentially an iteration in that process. Now, it's a colorful iteration, and it's certainly interesting. And I think in terms of what's happening in D.C. today, I would just say what we're seeing is a grand negotiation. The Freedom Caucus, made up of 30 to 35 members of the Republican caucus, have taken the position that this is not conservative enough for them, and they're not going to vote for it. I believe what they were really saying to Donald Trump and to Paul Ryan is, you can't do this without us, and we're going to demonstrate our relevance. And we're going to do that by digging in on a hard line. And I believe that they would have done that if taxes were first. But then you saw Paul Ryan and also Donald Trump do exactly what they had to do, and that's to say to the Freedom Caucus, well, if that's what you're going to do, we're walking away. You're now stuck with what you don't want. And so what we've seen now is a part of this 40-year process, this reiteration. We've now just reached a point where they can begin to have a serious negotiation, and that's playing out. I'm still of the view that we're going to a bill. I don't know what will be in it, but it will be referred to as the repeal and replace bill, because the Republicans have dined out on that phrase for a long time. And we don't know the definition yet of repeal, and we don't know of replace. There will be changes, but it's not going to be this much change. It's going to be this much change, and it will be an iteration that fits into this 40-year transition that we're making to keep our system sustainable.
Well, that gives us a good landscape, and your sense is that we ought not to look at this myopically. We got to look at it broadly and from a higher perspective. What do government and private sector leaders need to do to begin to either facilitate, to move forward, or even to accelerate the movement to value?
I think we have to confess to ourselves that this is a very significant change, and we're not very good at it yet. The reality is that this transition requires us to learn new competencies. And there's a bit of a challenge right now in that the payers, including the government, are trying to move that transition faster than the providers are willing to go or ready to go. And it's that push and pull that becomes part of what determines the speed. And we're seeing that it's happening differently in every medical community. But underlying that transition is one very basic truth, and that is we have not yet established even a common language about how this works, and it's limiting the speed with which it can occur. We did the same thing in medical records, electronic medical records. As many of you know, I spent a lot of my time trying to develop interoperability with medical records. I believe we're beginning to make some of the same mistakes in value payment that we made in electronic medical records, in that we have not yet defined the standard definitions or developed the competencies. So with electronic medical records, we developed the systems, and we had 200 different systems that couldn't talk to each other. Well, with competency development now, or with value-based payment, we're calling the same thing different things. And so we're working very hard with a whole lot of other people. Dr. McClellan and I, for example, are chairing a group that's trying to define the language of competency and value care. And I think, so what I'm suggesting is we have to keep pushing. We can't move too fast, but what will speed it up is beginning to create common definitions so that we're all speaking the same language and able to move interoperably.
So it appears that the states are going to play an increasingly more important role, and that Medicaid will be subject to opportunities for innovation and the like. Just curious about your reflection on where we might see that go.
Well, let's talk about Medicaid generally. In the same way that the words repeal and replace are, in my judgment, directional slogans about having less government, I think the words that are being used around Medicaid block grants are similar. Medicaid block grants mean mean different things to different people. If you're the governor of the state, in your mind, a block grant is the federal government leaving money on the stump in the woods at night, and you'll take care of everything after that. To the federal government, to the Congress, block grants mean we're simply going to limit our exposure and give us certainty financially, because if there are surges, we don't want to be responsible for that. Well, we're now fighting through. I've been through this 3 times in my role as a former governor and former Secretary of Health, and I think what we're going to end up seeing is that the federal government, likely in this new iteration, will take a similar amount of money that they've had in the past. They'll have to split it up among more states, and that there's going to be proportionally a little less money in the final analysis for states, and that they're going to be forced to find ways to do things more efficiently. And in my mind, that means not just cutting payment rates. They're going to have to move toward value and between contracting with Medicaid payers. And I think that's going to begin to force us all to not just change the way we pay, but it's going to force us to change the way we deliver. That in order to meet that economic pressure that's going to come as a result of this, we're going to see more economic pressure to do the same amount of quality or more with less money, and that we're going to see the nature of the way we deliver Medicaid need to change, and that there will be, in fact, some additional flexibility for states to try those things.
There's been a little discussion at this conference about the social determinants of health and the influence that they have on the healthcare outcomes. How do you see the private sector and government working to help this transition to value care as it's reflected in incorporating social determinants?
I believe that words social determinants on health are going to become a very significant discussion. We're spending a lot of our time thinking about how you actually do that. But in my mind, it is right in the heart of this transition between fee-for-service and value care. When I was governor of Utah, it's a small state, and we had the ability to have, as a result of that, a bit more granularity on what's happening on the street. And it was evident to me that not only were we serving families on Medicaid, but we could make lists of families that we were serving in 5 or 6 different state agencies, the same families. And so occasionally we would try to get together at a table and talk about each family and who was serving, because we had 6 different people, and it didn't work. And I think what's happening now, as we begin to see states having to deal with less money, they're very clearly going to start reaching out for more managed Medicaid programs, and they're going to say to them the same thing the federal government's saying, we want more certainty, and they're going to begin to contract with outside providers. And those providers, whether they're hospital systems or insurance companies or third parties, are going to say, we've got to have more control or more influence on what's actually affecting their spend. And I think that we'll start to see states contract not just for Medicaid with Medicaid providers, but also other human service programs that the state now conducts, and that's where a lot of the experimentation will go on the social determinants of health. And again, I think it's part of the maturation of this transition, this 40-year transition that we're about 25 years into. In the next 15 years, we've got to figure out how to do this, or we won't be sustainable economically.
Thank you. The providers need data and they need tools if they're going to move towards value-based arrangements. And just curious your thoughts about what the market's doing to respond to that need and what the market needs to do to more efficiently respond to that need.
Well, look, I think we ought to just start where we left off on the last question, and that's Medicaid. I think Medicaid and Medicaid data will become among the most important tools that we have, particularly as it becomes more directed toward managed care and we integrate the social determinants of health. I have said to many that I believe the new frontier of innovation is going to be learning how to create a value proposition and replicate it to where the point that a payer will make an investment that will result in lower cost. And that's going to require data. And our skills at being able to refine that data has to increase, and our ability to manipulate data into pictures and stories so that it can be more easily used. We've been doing a lot of this recently with healthcare markets, and I think once we begin to combine healthcare markets with clinical data, we're going to get much more insight into it, and I think Medicaid data will have a great influence on that.
So we've gone through this kind of massive experiment over the last 8 years. You've referenced it as 25 years into a 40-year transition. Have we learned enough about costs and quality now that we've addressed the access issue and expansion seems to be here to stay? Have we learned enough, or what do we need yet to learn?
I'll go back to what I suggested. We are not a long ways into this. We keep very close tabs on how many lives are being managed under some kind of provider risk contract, and it's still less than 15%. It's rapidly expanding and has dramatically expanded in the last 5 years, and we believe it will continue to expand even more. But the fact that we have one foot in the canoe of fee-for-service and the other in the canoe of value payment clearly demonstrates that it is not sustainable, and we've got to get better. And it starts, I'll go back to what I said, we have to define first the language, then we have to develop a common way of talking about it, then we have to create standards and a way of communicating about it so we can measure our progress, not just for our own self because we're taking risks, but because now we're going to be dependent on other people having those competencies in order to achieve a financial result that sustains us. So knowing how much your neighbor can do and knowing how much your collaborating organization can do is going to be important, and that's a very important skill that we haven't yet mastered, but we're making progress on.
You referenced earlier the chairmanship that you and Dr. McClelland have relative to an accountable care organization, and there clearly are some lessons that are being learned about the competencies, and in fact, it's focusing on the competencies. How do you reflect on those in terms of the importance that they have in the development of value-based care?
Anytime you're trying to bring order to something where there's chaos, you need to begin to develop standard ways of talking about things, and so you can communicate. The old biblical story of the Tower of Babel is a good example. They all wanted common things, but they were speaking different languages, and as a result of that, they began to sort of break up into different groups, and those groups then competed against each other in unhealthy ways. And the same thing will happen to us here. We have to develop this language, and there are only 3 ways that we can do that. And that's true for all standards. You can either depend on the government to do it, and frankly, that may not be the highest order of priority for the government right now. And if they do it, I know from experience, they may not get it right. That's option 1. Option 2 is to have what I call the last vendor standing. That is, somebody's going to come up with a system that's so good everybody will migrate to it. Well, it didn't happen with electronic medical records, and it won't happen with value payment. And so the third option is the only one, and that is we have to collaboratively develop it. And it will need to come from the industry. And so Dr. McClelland and I have, along with a number of other people, acting as conveners from some of the larger government organizations and industry groups and individual organizations, have begun to convene this thing we call the Accountable Care Learning Collaborative. And we actually are asking people to join us in helping to figure this out. And there'll be people in your audience, frankly, who we need, and they're not involved in this. But if we don't get this early, we're going to end up in the same place we did with electronic medical records. We've been doing this for years. We've been spending billions of dollars, and we're still not interactive. We need to do it now while we've got the chance to do it right.
So we've got about 3 minutes left, and I wonder if you just have any final thoughts you'd like to, that you haven't had an opportunity to express that you'd like to.
Well, I would simply summarize what I've said. And first of all, I believe that what we're seeing in Washington is yet another iteration on a 40-year transition of 20% of the entire economy. I think it's being driven by economics, not just politics, though the politics are going to be important because they represent our refinement and iteration toward that. I think there are 3 things you can get Republicans and Democrats to agree on. One is that fee-for-service is the problem. The second is that coordinated care is better than uncoordinated care. And the third thing is we have to make whatever combination of those we do in a way that will save money. And I think we are making progress, but it's not happening as fast as we can make it. We have to begin to speak a common language, and we need to work collaboratively to get that done.
So I've heard you in the past suggest that that this is a train that's left the station, that it is inevitable that this move will occur, And you've suggested with regularity that there are going to be people in the healthcare community that fight it and they're going to die, that there are those who will accept it and they'll survive, and that there are those who are going to lead and they will prosper. Any thoughts about the prospering end of this? I think that's where this group would like to focus.
I believe this problem, every generation of Americans has had a challenge that they had to face in order to be worthy to be called the greatest nation in the world. And I think this problem of health care and its increasing, the increasing percentage of all the resources we have to do everything that makes us competitive, this is our generation's challenge, and it's going to require serious change. And change has always rewarded those who lead it. And I don't think that leadership will always come from the government, though they have to play a role. It will have to come from people who can learn the new competencies, can apply them, and can teach others. That's the American way, and that will lead us to a uniquely American healthcare system. I'm optimistic.
Governor, thank you. We appreciate it, and there's a whole room full of people I know that are appreciative of you making arrangements to be with us today. Thank you.
Thank you.
Thank you.